Hi everyone, today I'm here with Dr. Gutierrez, an associate clinical professor and obstetric anesthesiologist who's been practicing at the University of California, Davis Medical Center for 8 years.
Mm-hmm.
So thank you, Dr. Gutierrez, for being a part of this interview.
My pleasure.
And before we go into anesthesiology, could you briefly explain what anesthesiology is?
Anesthesiology refers to the physicians that take care of patients during surgeries and during procedures requiring either general anesthesia, which is complete loss of consciousness, or some sort of sedation, or even regional anesthesia, which only involves a portion of the body.
You mentioned that you're an obstetric anesthesiologist. What does that involve, and what are the other subspecialties of anesthesiology?
So obstetric anesthesiologists specifically dedicate to make sure that the mom is safe during labor and that she is comfortable, and that if she needs a surgical intervention, that is done on a safe way, so allowing the best conditions for mom and a baby. There are many special considerations during pregnancy in terms of physiologic changes that we need to have having to consideration when we do an anesthesia for an obstetric patient.
Okay, and what are the most common procedures or considerations or types of cases that you deal with as an obstetric anesthesiologist?
Well, the most common will be labor analgesia, so labor epidurals, which is a placement of a catheter in the back of the patient to make sure that the pain is gone from contractions, and the cesarean sections, which is the surgical intervention that we most commonly perform.
Why in particular did you choose obstetric anesthesiology as a subspecialty?
My passion has been maternal safety, and when I was in med school, I was kind of debating into obstetric versus anesthesia. But then I realized that what I really was passionate about was making sure that the mom was comfortable and safe, and that anesthesia was the best way to approach that.
Mm-hmm. What is a typical day in your life like from when you come in to when you leave?
Our days are it varies because of it all depends on what's happening on the floor. So, but basically, in the morning I come here about 7 a.m. and there is a sign-out meeting which involves obstetricians, nurses, and anesthesiologists, where we run the board and talk about every single patient and what's new and what's happening, what's the plan for the day. After that, we do, if there's scheduled cesarean sections, then we get ready for that. And then during this time, if there is any epidural that needs to be done, then we perform those procedures, or if there is any consult that needs to be done. So every day is a challenge. Every day is something new.
What are the hours like usually? You said it starts around 7. Does it go till about 7, or is it?
Well, here at UC Davis we work on shifts because we need to cover the service 24/7. So we work during the day. Our shift is 7 a.m. to 5 p.m. and the night shift is 5 p.m. to 7 a.m.
And how many days on would you be, and how many days of call do you take?
I have about 2 or 3 night calls a month, and about 1 day call and 1 night call during the weekend. But I like to combine them, so I do like a 24-hour shift. And then the regular days will be, it's 3 or 4 days a week. Mm-hmm.
Okay, and how is the lifestyle of an obstetric anesthesiologist different from maybe another subspecialty anesthesiologist, and how would that be different from maybe a doctor in a different specialty?
Our practice is quite different from somebody working in the regular ORs. When you work in a regular OR in the private practice, you have a schedule, so you know what you're going to do, and most of the day you always follow that schedule, and those are the patients that you see. Here we have a combination of scheduled cases and also things that are not planned. Patients have labor anytime, so it's like a combination of ER and scheduled OR at the same time, but only for pregnant patients.
I'm assuming you're not going to be in clinic during the day. Are you just like in the call room, or what happens in that time where like you're scheduled and there may be a patient that needs to be seen, but you haven't been called in yet?
And during the day, I can be teaching the residents. Sometimes we have med students, so teaching the medical students, preparing for lectures and stuff, or taking care of patients. So our cesarean sections take about 1 or 2 hours in performing procedures, basically epidurals on patients. So if I'm not doing that, I will probably working on my computer. I like to be we have a call room, but I like to be at the boardroom where the obstetricians are, because that way it's a faster communication than when I'm in the call room, because otherwise they will have to call the residents who will call me, so it takes a longer time. Mm-hmm. So I like to know what's happening before it happens.
And how much like pre-op or post-op care does an anesthesiologist do? Besides, it seems like the bulk of what they do is more centered in like the actual like the sedation and things like that.
So we usually evaluate the patient for the scheduled cases. We evaluate the chart from the day before. Sometimes many days before, depending on how complex is the case, the surgeons or the obstetricians should usually determine which patients we should see in advance. And then the patient comes, when it is a scheduled case, the patient usually comes about 2 hours before the procedure. So we go to the place and do like a physical exam, history and physical, to confirm what we have seen and to do a physical exam. And then we are in charge of taking the patient to the OR, be there with the patient during the entire time, and then we move the patients to the recovery unit. It's called the PACU, and there the patients are still under our care, but the nurses are the one-to-one with the patient in there. But when the patient has recovered completely from the anesthetic, either the general anesthesia or the regional anesthesia, then we evaluate them again and make sure that they're safe and send them wherever they go. Sometimes they go home, sometimes they go to their room.
Okay.
Yeah.
Mm-hmm. Okay, and so what's the most challenging aspect of being an obstetric anesthesiologist?
Maternal physiology is very complex, and it differs. It's different from the non-pregnant population. So baseline there are challenging in terms of increased cardiac output. All hemodynamics are different. Respiratory mechanics are different, and when the patient is healthy, it's very easy to take care of them. But when the patient is complicated, we have to have in mind not just the issue that is happening, either the bleeding or cardiac issue or whatever is happening, but also all the other changes that she has had during pregnancy, and the fact that there is a second person there, which is the baby. So mom and baby should be safe during the procedures.
And what's the most rewarding aspects of being a obstetric anesthesiologist?
the smile of the mom when we perform an epidural and she's in horrible pain, and 10 minutes later she's pain-free. That's one of the biggest rewards that we get. And also during the surgical procedures, the fact that we can have the mother awake while they're doing a surgery, so she can see her baby, she can do skin to skin to her baby while they're still working on her. That's another very rewarding situation.
Are there any misconceptions about obstetric anesthesiology or anesthesiology in general that you've encountered?
Yes. So there general population misconceptions and also anesthesiologists or physicians misconceptions. So from the general population, there is the belief or the idea that when a mother comes to deliver a baby, the anesthesiologist is trying to force her into having a procedure, having an epidural or something. We are there to take care of them. We are there to make sure that they're safe and that whatever they need in terms of if they're bleeding or if they're like anything that happened to them, we're there for them. And obviously, we're there to take care of their pain. But the pain control is very optional. It depends on what she desires and what are their expectations from childbirth. So we are not trying to force anything into any patient. We try to work with the patients and make sure that what their idea of how this birth was going to work is kind of follow with the plan. You can never follow the plan completely, but also we are there to advise the mom what is the safer approach. Sometimes they have very strict ideas of how their childbirth should be, and childbirth every time is different. You cannot plan it, so things change. Patients that are completely healthy may end up requiring a surgery or a transfusion. So those are things that we need to anticipate and we need to discuss with them. The misconception of other anesthesiologists regarding obstetric anesthesia will be that that's easy, that all we do is epidurals. And what we do is taking care of the entire process, not just the pain control, but also all the surgical procedures, even postpartum procedures like postpartum tubal ligations or DNCs that can happen.
Are there certain personality types or certain qualities that are best suited for obstetric anesthesiologists or even anesthesiologists in general that you'd find in medical students?
Well, for obstetric anesthesiologists specifically, we need to be flexible. We need to be able to communicate, because this is a work. It's completely teamwork. The obstetrician needs to communicate with us. We need to communicate with the nurses. The nurses need to communicate with the obstetricians, and we all need to communicate with the patient and the patient's family. So that's the basis of all the interactions that we have with the patient. So communication and flexibility, because again, things change during labor and delivery. Things that are scheduled may not happen. Things that are non-scheduled or non-expected may happen. So we need to be able to change our gear at any time. In terms of anesthesiology in general, the anesthesia involves instant gratification, because what we do, the medications we give, everything works immediately. So if something takes 5 minutes to a medication that takes 5 minutes to act is like an eternity for us. We cannot give a pill and wait 3 months to see how it worked. So it's all. That's another beauty of anesthesia, that we do something on the patient and we see the result immediately. But we also need to be able to respond fast, because changes happen really fast. Somebody might stop breathing, somebody may start bleeding. So things that are life-threatening can happen really fast, and we need to be able to immediately act and be able to respond to that. Our good days are boring. If you don't notice the anesthesiologist, that means everything is going fine. If you have to interact with the anesthesiologist a lot, then that means the patient is having a lot of issues. We don't do clinic. Only certain subspecialties we do clinic, like especially chronic pain we'll do clinic, but in general we don't do clinic. We do preoperative clinic, but sometimes it's 1 day, like, or sometimes depending on the practice. Some practices have like a nurse anesthetist doing it, and the anesthesiologist will only see the patient if there's some special situation. But it's not a clinic, like established clinic per se. Mm-hmm. We usually don't round, unless we have some subspecialty will round again. Chronic acute pain will round, obstetric anesthesia will round, but in general we don't round. We don't have clinics, so that's another. Our interaction with the patient is very short, so we need to establish trust in the patient in a very short period of time. We meet them in like half an hour before they go into the anesthetic. So we need to be able to establish that trust really fast.
Mm-hmm. Okay, so for someone that's interested in anesthesiology or obstetric anesthesiology, what tips would you give medical students to match into a competitive anesthesiology residency and then an obstetric anesthesiology fellowship?
Obstetric anesthesiology is a subspecialty, so it's something that you usually decide during your residency, after you're exposed to all types of anesthesia. In order to match into anesthesia, well, it's basically the same things that other specialties, I imagine. Having good score in the steps, and the most important thing will be you're really interested on it. You need to have a real, evident interest into anesthesia, not that much into the lifestyle or the salary, but actually interested on it, because this is a very intense specialty. As I told you, we can be like, we can have a completely boring day, or we can be doing CPR on a patient, and then next we have to go and do another procedure. So it's very tiring, and in terms of not just physically but also mentally, because we need to be aware of everything. So you really need to like it, and for that I would recommend that people be exposed to anesthesia. It's hard for you guys during medical school, because anesthesia is not a basic rotation, so you have to it's an optional, but get exposure to anesthesia is really important, so you can see what we do and maybe understand what's happening behind the curtain.
Kind of going into the business or employment side of things, what practice settings and employment types are there for anesthesiologists? You mentioned like private setting, and then you're obviously an academic physician. What other settings are there, and maybe what are like the pros and cons of each?
So most common would be private practice, and it's usually people work in groups, and they work on shifts, and some practices require night shifts, some other not. That's the most common setting. I work in academic, so we also have to provide education, and we need to cover 24/7. So, and there's also locum tenens you can do. It's less common, but is increasingly is growing because it gives people freedom to work the schedule that they want. So if they need some time off, just take it, and if at some time they need more money, then work more. Or yes, it allows more flexibility in your regular schedule. Depending on the specialties, if you are a chronic pain specialist, your lifestyle is completely different from ours. The chronic pain specialists have all that we don't have. They have clinic. They have a 9-to-5 schedule. They do procedures every single day. So their lifestyle is completely different than ours. Everything depends on what specialty you pick. If you are a general anesthesiologist, we usually work in a group. They always work in a group, but if you're a cardiac anesthesiologist, you may need to do to be on call more. If you are a pediatric anesthesiologist, also, we usually don't work solo. We don't have like our own practice because we need a surgeon. So the most common practice is groups.
How well are obstetric anesthesiologists generally compensated? How well would that be compared to like general anesthesiologists, or and how is that relative to other physicians?
Well, obstetric anesthesiologists unfortunately don't get any extra compensation just for that. It's a subspecialty that was approved by ACGME recently, so we're like a growing specialty. So our salary is not much different than any other anesthesiologist. In general, anesthesiologists, we're kind of in the middle. It's better than the primary care physicians, but not as good as, let's say, plastic surgeons. So we, in general, are able to have a good lifestyle.
Okay, and are there certain ways anesthesiologists or an obstetric anesthesiologist could make more? It seems like the more procedures you do, the more you make, but that's more limited to the cases, especially if it's like obstetrics. It seems like you can't control it as much.
That will depend on the model that your group approach, because some, like here at UC Davis, we have a salary, and the hospital charges the patient a package for the regular stuff, and so it doesn't matter if I do 10 epidural and 3 C-section in one day, or if I don't have anything to do in the same day. I will be compensated the same. But when you work in smaller groups, then it will depend on your volume and how many procedures you do, and how complex are the cases. So it depends on the practice.
All like the advances in medicine, how do you stay on top of medicine and anesthesiology and obstetric anesthesiology in particular?
In general, anesthesia has evolved from very basic, minimal monitoring of the patient back in the day to now very complex ultrasounds, invasive monitors, minimally invasive monitors that will tell you hemodynamic parameters, that will tell you cardiac function, that will tell you volume status. So now we're much better equipped to actually evaluate the patient status and be able to respond to what's happening.
Mm-hmm. And so how do you keep up with all the changes? Do you read papers and go to conferences, or is there other things you do? Is that most of what you do?
Yeah, we have to, sometimes we have to train, like especially recently within all the new ultrasound developments. There are a lot of workshops and updates that we need to, that we attend to. In obstetric anesthesia, specifically, there is a meeting every year led by the Society of Obstetric Anesthesia and Perinatology. So in this meeting, we learn about the latest developments, but we also reinforce or get into an agreement for the normal care of the patient. General anesthesia updates everywhere. There are ultrasound workshops everywhere, pretty much. We need to keep updating constantly. So the ABA, the American Board of Anesthesiologists, has developed something that is actually, I think, is very clever in terms of maintenance of the certification. Usually, every specialty, the way they do it is they have an exam, like a board exam at the end of the residency, and then nothing for 10 years, and then in 10 years you need to demonstrate that you went to X CME credits and do another exam. So the ABA developed these quarterly evaluations that we do in our computer or in our phone at home. And it's an evaluation that allows us not just to demonstrate that we're updated, but also we learn from it. Because it gives you the question, but it also gives you the answer after you respond. So it's much more interactive, and I think it's much more effective in terms of keeping up with the latest things than having an exam every 10 years.
So you mentioned that anesthesiology can be pretty intense. How do you, with all the intensity, I'm sure there's a lot of burnout. How would you recommend dealing with or preventing even burnout?
This is a difficult topic, and we haven't developed like a good system, and it's very easy to be burned out in anesthesia because we have night shifts and some places long shifts, and it's very important to take care of your personal life and don't forget your personal health, because it can be easily forgotten. During the day, in private practice, there are places that the anesthesiologist has like 5 minutes to eat in between surgeries, and so use the restroom. Like, people don't drink much, so they don't have to go to the restroom and things like that. So practices, the smaller practices are, I think, harder because there's less flexibility than big practices. In obstetric anesthesia specifically, we have long shifts, but we also have days in between that allows us to recover from those shifts. So it's important to use those days or the time off that we have to engage with our families and friends and do things that are outside of the medical field, not just dedicated to medicine or research. because it's very easy to be burned out, and unfortunately, it's also for physicians in general, but especially for anesthesiologists, it's very easy to. We have access to drugs, so people resort to taking drugs, and people die for that. So keep an eye on yourself, but also keep an eye on your coworkers, and be supportive of each other, and understand that everybody makes mistakes, and that nobody's perfect. So take care of yourself. Have a family life, and be supportive of your colleagues, and those are the main things.
Okay, and you mentioned having a family life. How do you establish that work-life balance?
It's difficult because my shifts are like I don't have a set schedule. So general anesthesiologists in private practice have a set schedule. They go to work at 7 and finish, I don't know, 5, 3 or whatever. But my schedule changes month to month. So 1 week I can be working nights, and next week I'm working. So it's very hard for me to have routines at home or things like that. But what I try to do is every time I'm at home with my daughters, spend time with them and dedicate time to be there and be with them, because sometimes some weeks are very hard, some weeks are easier. We need help usually, so I'm lucky that I have a stay-at-home husband, but many women are married to physicians, so their schedules are crazy as well. So it's very difficult to have and you really need to be conscious on creating that space for your family.
How has medicine changed since you started practicing, especially like anesthesiology, and where do you see it going in the next few decades? Are there any big advances? You mentioned that obstetric anesthesiology recently became like a recognized subspecialty. Are there any like special changes that you see in like the next few decades?
Well, that's the biggest change, that now we're recognized. In terms of technology, there are a lot of advances in patient monitoring, ultrasound, also even the anesthesia machines are constantly they're constantly evolving, and the ventilators are, every time a new anesthesia machine comes up, the ventilator has more whistles. So a lot have changed. We have way more tools right now to take care of our patients, to evaluate their status and make sure that they're doing well.
Okay, do you feel CRNAs will take over a lot of the anesthesiologist role, like in obstetrics or other?
If we let them, they will try. And this is very dangerous because they have a very important role in the anesthesia practice. There are many cases that can easily be managed by a nurse anesthetist, but there are some situations that need the extra preparation that we as a physicians have, and knowing we are way more prepared in terms of knowing all the physiology, all the pharmacology. Don't get me wrong, they're prepared on that, but we have way more extensive preparation. So our role needs to be complementary, not excluded. So we can work with them. They can take care of our easier cases, but there are some situations that require a physician, and even a specialized physician in that area. Some neurosurgeries won't. CRNA will not be likely to be able to take care of a complex neurologic patient or cardiac patient. In OB, there's a lot of CRNAs taking care of obstetric patients, but in a higher level of care, you need a physician. And you need a physician, an obstetric, like a specialized obstetric anesthesiologist. Even compare with the general anesthesiologists, patients that, places that have a dedicated obstetric anesthesiologist have better outcomes. So, no, the CRNAs are not completely gonna take over our specialty, but they are trying to work in a way that, their idea that they can work independently is they're gonna hate me when this comes out. I'm gonna get a lot of hate. Even though the nurse anesthetist preparation is extensive, the physician preparation it allows us to take care of the most complicated patients and the most complicated, the most devastating complications. We can have complications on a normal patient, and a physician anesthesiologist will be way more prepared to take care of those unexpected situations than a nurse anesthetist.
If you could go back, is there anything you'd change about your career, or maybe like the specialty you chose, or subspecialty, or anything else?
I love my career, and I love my specialty, and I love my subspecialty. So no, it was a long preparation process. So if I knew that I was gonna end up here, and at this point in my life, that I will have moved towards that goal earlier than what I did. It took me a while, and it's a long process. So that takes a lot. But no, I will not change what I pick and choose.
And last question: how do you become, or what tips do you recommend so we can become good doctors?
You need to care about the patients. The main thing that I tell people that are applying to med school, or asking me if they should apply to med school, is that you need to love medicine, because this is a career that will take a lot of your life. And so if you are thinking that will give you a lifestyle that will allow you to get money or something like that, that's not the reason you should go into medicine. You need to really care about what we're doing and really care about the patients. So that's the main thing. You need to love medicine, and pick a specialty based on what you are passionate about, rather than what will be more convenient for you or for your family, or what your family wants for you to do. Listen to the patients, be mindful of the patient, be compassionate, and keep updated.
That's good advice. Well, thank you again, Dr. Gutierrez, for being a part of this interview. And thank you guys so much for watching. If you have any questions about anesthesiology or obstetric anesthesiology, feel free to leave it down below in the comments, and I can ask Dr. Gutierrez and get back to you guys. Thank you guys again for watching, and have a great rest of your day. Take care.